أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. My dear fellow students, colleagues, and others who are watching these videos, I'm taking actually a very long chase of what is called infectiology, infection and the disease. And I was actually continuing with the fungal infections first of all. And fungal infections, they are definitely important to learn and to study it and to remember it whenever the case will present to you. So it is a big one, that is the fungi or mycosis. And the subject is called mycology. Actually, this is called mycology. And look, the people do in microbiology and MPhil in mycology, PhD in mycology. So there are different types of the fungi, actually, one should understand that. My friend said that why you are taking so rare things. These are not rare things. Actually, the thing is that you will actually, when you are diagnosing, differential diagnosing, you should keep under last line or under 3 afterwards from the bottom this differential diagnosis. Because if you can understand it properly, you can diagnose it. Otherwise, you cannot. Because dermatologists nowadays are cosmetic dermatologists, basically. They are not the persons. At one time, they've done MRCP and they've done DTMNH and then done DDAM, etc. And they actually took experience in this field. Like our most of the our teachers who were running the boards of dermatology. So that is the thing about dermatology is an important subject. It is not a part of dermatology. It is a part of the internal medicine, mostly. Although the skin manifestations are more common with the fungi or mycosis. First of all, you should understand what do you mean by this terminology fungus. They said that the fungi are eukaryotic, means that those organisms which have got the nucleolemma in their cells, nucleolemma, then they are called eukaryotic type of cells. And those organisms which have the nucleus without membrane or DNA only, and that is the DNA main genetic composition of the cell without any cell membrane. They are non-muscular, they are non-motile. Motility is at one part. Non-motility doesn't mean that it will not move. It moves at one point, here and there, forth and there. And heterotrophic organisms, what do you mean by the heterotrophic? Heterotrophic organisms are those organisms which are dependent for the nutrition and therefore the energy cycles. They are dependent on the outer environment, external environment. And those organisms which can make their food themselves inside is called the autotrophic organisms. So these are the heterotrophic organisms. They are dependent on the surrounding environment for their growth. They may be unicellular, cellular or filamentous type of organism, maybe just like a cell only, and maybe like filaments. They reproduce the means of the spores to the other part of the surface. They will produce the spores will spread and will regrowth. Fungi exhibit the phenomena of alteration of generation. When they are generating it, there may be a possibility, there will be a revolutionary cycle is going on. They are more resistant to manage it. They are more invasive day by day. The fungi look like the chlorophyll, although at one time they are considered in the plant kingdom. Then at one time they have been classified as the animal kingdom, and the third part of the study is done. They said that some part is very very similar to the plants, but the other parts of the organisms and their habitat and their properties are very similar to the organisms, means the living organisms, like animal kingdoms, unicellular. So they are lack the chlorophyll, therefore they cannot perform the photosynthesis. They are dependent on the outside, the environment and external environment. So this is how they are fungi are classified or defined. Now this is a typical structure of one fungus. That is, this is the sporogenium, this is the filament, and the spores are there. This is called sporangium. It bursts out and releases the spores. There is stalk. This is called stolon, and there is a hyphae in which the penetration occurs on the surface. It moves here and there, here and there, here and there, but not this part to the other part. They move and they produce pathogenicity by spores. So this part, the spores will, spread, and then again fungus, then again fungus, then again fungus. In this fashion, they are penetrating the living cells or animals or plants. The classification should be done like this. For example, those organisms which are superficial organisms, fungi, those fungi which are subcutaneous, basically, and third are the deep fungal infections. The most mycoses traditionally divided in superficial, subcutaneous, and systemic, where infection is deep, more widespread, involving the internal body organs. They can affect the nails, vagina, skin, mouth. Some types, such as blastomycosis and cryptococcosis, coccidioidomycosis, or staplasmosis, affect the people who live or visit certain parts of the world. Others, such as aspergillosis and pneumocystis. Now, pneumocystis is one organism which is very important in the HIV infection. Pneumonia, candidiasis, mycormycosis is a very important invasive fungi, and tularomycosis, a new one, which can penetrate in the surfaces and it can spread in the body, tend to affect people who are unable to fight infection. Immunocompromised patients, they will develop these type of the fungal infections. Some superficial fungal infection can cause systemic infection if they are penetrated out. They are not treated on the proper time. In people who are immunocompromised especially, these superficial can cause the systemic infection. Some subcutaneous fungi infections can invade in the deeper structure, now resulting in the systemic disease like Candida albicans can live in the people without producing symptoms and is able to cause both mild candidiasis and healthy people with a severe invasive candidiasis. And those who cannot fight the infection themselves, that is CD4 deficiency or HIV infections. Now I will take the superficial fungal infections, although it is a big chapter on the superficial fungal infections, but one should learn of these fungal infections. By hook or by crook, they have to learn it. Otherwise, you are appearing in the examination, you should know the knowledge about this subject. If anybody will ask you in anywhere else, any part of the world, you can answer it. 100% achievement of the knowledge. Otherwise, you will be lacking in the knowledge. The superficial fungal infection are caused by the dermatophytes. Although they are very, very superficial. In the epidermis, there are layers of the epidermis. They are penetrating the epidermis, the second layer or third layer. And they are called the microsporum. This is of the species, genus Trichophyton, and Epidermophyton genera. Now these are three: microsporum, Trichophyton, and Epidermophyton. Dermatophytes live on the keratin, which is found in the skin here and there. This is the habitat. There is evidence that continuing migrations and mass tourism contribute to the changing epidemiological trends. That is why they are changing. A revolutionary cycle going on. So very difficult to treat them. Tinea infections are named according to the Latin term that designates the anatomical site of the infection, such as Tinea capitis, scalp, Tinea corporis, the body, Tinea manum, the hand, Tinea cruris, the groin, and Tinea pedis, foot, and the Tinea unguim, nail. Remember these terminologies if you can: the Tinea capitis, Tinea corporis, Tinea manum, and Tinea cruris, and Tinea pedis, and Tinea unguim. Let's start with the Tinea pedis foot rot. So Tinea pedis, collectively known as the athlete's foot, because they are using the shoes, and the army also. It is the army important infection of the skin. They discard the soldiers to work hard. If they are infected foot are there because they are painful, and it is the most common dermatophyte infection. Its prevalence increases with age. It is rare in the children. Exposure to the occlusive footwear, sweating, and the communal spaces are predisposing factors of the tinea pedis. Actually, when I was serving the army, I have written paper on it, although it was not published afterwards. Research on it, why they are affected, and what are the stages of the disease. And that is the aim of my study. I have done, I think, 3,000, 4,000 people have been examined who had positive tinea pedis. And this is a long discussion I don't want to discuss. The interdigital subtype is the most common form. Means the toes, between the toes, there is a space, the sweat will collect, and if it is collected, it is the very good, you can say, culture media for this infection. Another subtype is the chronic hyperkeratotic, which is called the moccasin type tinea pedis, which is characteristic by the chronic plantar erythema with the scaling involving the lateral and the plantar surface of the foot. It is less common. The dorsal surface is usually spared in subtype. A less frequent presentation of the tinea pedis is the vesiculobulbous bullous or inflammatory form, which may sometimes be difficult to clinically distinguish from what is called the Pomphylix type of eczema, because it is itchy and it has a fluid coming out. Recurrent tinea pedis may be due to the revive of untreated tinea in the nails. I mentioned out previously, this is very important in the army. If somebody has got this problem, he will gain the rest. Otherwise, it should be treated properly, because the boot is very long, soldier's boot, and a lot of secretions are inside the boot, and which may be rotten type of a smell, because they are always running and going out with these socks and these boots which are of pure leather, and it is fitted in on the both sides of the limbs, and should be done like this, definitely. But the problem is this: okay, if the sweat will be collected specifically in the small fingers and the third toe, it is mostly commonly seen there. Like for example, here you can see this is the part which is involved here. This is the part which is involved. This is the plantar pipe. Otherwise, it is most common time with small fingers, toe, and surrounding toe. This is the most common sites. And then the treatment part will be taken in the end, actually. Tinea unguim, which is called the onchomycosis. The tinea unguim means, also known as onchomycosis, is the dermatite infection of the nails. It is unguim. Manum is from the hands, unguim for the nails. The onchomycosis is very common in the elderly, with the prevalence of up to 50% people aged over 70 years. Nearly half of the patients with the toenail onchomycosis were found to have the concomitant fungal skin infection, most commonly tinea pedis. The most common clinical subtype is the distal lateral subungual onchomycosis that appears as a yellowish or a brownish discoloration associated with the oncholysis and subungual hyperkeratosis. This is a very difficult problem because the patients, they are involved like Dhobi, those people who are going for the religious ablution, wuzu, for example, they don't dry this and their hands, and this is a good culture media because the water will be remaining in the roots of the nails and they cause this problem. Or those people who are living unhygienically, they can they can be checked with this infection, and the nail plate that can involve the entire nail, if not treated, the whole nail will be gone. It's very, very common. And mycology has many mimics, so it is important to establish a mycological diagnosis before commencing therapy. Individuals with underlying nail disease are increased risk of the concomitant onchocerciasis. Immunocompromised and the diabetic hosts are not only at a greater risk of this, but are also more susceptible to bacterial complications, secondary infection of the onchocerciasis such as cellulitis. And see, the nail is all been engulfed by this infection. Ongoing. Onchocerciasis. So the nail is destroyed, completely nail bed is destroyed. He cannot cut short these nails. Around the finger is red. It should be, amputated. The nail should be, should be amputated from the root, and then new nail will occur. If you not treat properly, then the new nail will also have this problem. Yes. Remember, this is difficult, very resistant type of a problem. Now, those conditions which can cause the nail problems, they are written here, like chronic pyromachia, viral warts are there, like for example the chronic dermatitis, lichen planus can cause the nail, the psoriasis, and the 20 nail what is called dystrophy, and the trauma will cause the footwear and the manipulation, for example, the manicures, and it is the pedicures and the rubbings. Tumors called the Bowen disease will affect the nails, and the fibroma and the melanoma inside the nail. Now this is the part which I will take separately, because you have to differentiate between the onchocerciasis, between these two conditions separately. You cannot understand. So nails are a representative of something. That a lot of information can be collected if you properly examine the nails. Now another example, tinea capitis, is a dermatophyte infection of the scalp and the hair, and it predominantly occurs in the prepubertal children. The three main clinical presentations of the tinea capitis are scaly patches with alopecia with the black dots at the follicular opening, and diffuse scalp scaling with subtotal or subtle hair loss. A severe form of the tinea capitis is referred to as a carrion, is a black one, characterized by the tender plaque with the pustules and a crusting. It is a carrion, is a plaque, means that the other parts near to it are normal. But associated with the pustule and crusting, if untreated, the carrion may cause the permanent scarring and permanent hair loss. Cervical dermatopathy is common associated findings in the patient with the tinea capitis. You see these problems in the children who have got the pediculosis also of the hair. Now this is, you see, this is the part which is affected, which is annular region, crusting occurs, whole of the, scalp is involved, destructive nature of the disease. Another example is tinea corporis and tinea cruris, the Dobisich, because it occurs where the groin meets the abdominal wall. Tinea corporis is commonly known as ringworm. It is commonly called ringworm, although there is no ringworm at all. It refers to a dermatophyte infection of the skin of the sides other than the face, hand, feet, or absolutely on the groin is concerned. The tinea cruris is a Dobisich tinea corporis of the body. The tinea cruris is also known as chalk itch and occurs in the groin fold and is more frequently in the adult man. Cruris is concerned, Dobisich. Tinea corporis most commonly occurs in children and young adults. Tinea corporis and cruris classically present as annular plaques, the central clearing and the leading scale. The lesions may be single or multiple and of varying sizes, which may coalesce pustules of the vesicles can sometimes occur. At the active edge. Now see here, this is the tinea corporus. This is the Dobie's itch, very near to this. There is scrotum here. This is all over this. It is very itchy in nature. Children are affected, and those people who are not unhygienic, they are, especially in the summer season, the sweat collects at the sides, and it is a good media, culture media for this infection. Although it should be differentially diagnosed with corporus, with annular psoriasis, have got a scaly, shiny type of scales. Pityriasis rosea is concerned, which we will discuss. Is a reddish tinge in it. Pityriasis, the squat eczema will actually very itchy in nature, and it will definitely the fluid come out. Subacute lupus erythematosus I will already discussed this condition. It may occur as a annular form of lesions in the different parts of the body. And granuloma annulare is another dermatological differential diagnosis of the tinea corporis is concerned. Now, another very, very common is in Pakistan, especially tinea versicolor and pityriasis versicolor, because people have got in those areas where there is a deficiency of water, potable water, clear water. They usually took bath in the what is called as the small ponds, which are infected. And also in the cities also there is a problem of the water. Water actually is not generally available in the cities. Tinea versicolor is common fungal infection. Skin, the fungus interferes with the normal pigmentation of the skin, resulting in small discolored patches. These patches may be lighter or darker in the color than the surrounding skin. Depigmented and mostly affects the trunk and the shoulders, but it can occur on the chest wall. Tinea versicolor is a condition caused by skin eruption on the trunk and the proximal extremity. The majority of the tinea versicolor is caused by the fungus Malassezia globosa nowadays, although the Malassezia furfur is responsible for a small number of cases, although it is more commonly seen in the tropical zones. Now, this is a very important disease. Depigmentation occurs, वो कहते हैं कि कैल्शियम की कमी होगी, there is deficiency of calcium. Actually, the presentation is only a cosmetic. Itching very rarely occurs. In my experience of 40 years, more than that, I've seen many cases of this condition, and I actually diagnose on the examination. Why you are depigmented spots in your body, and under the deep examination of the skin, properly examination, it is found that it is a tinea versicolor or it is pityriasis versicolor. Remember, this is one of the most important problems in Karachi and other areas of the Sindh. Now, this is how they appear. Depigmentation, scaling, is slightly reddish tinge, but depigmentations, again, the fungal white spots and fungal brown spots can occur. And here you will see that the pigmented patches, although it is not very itchy in most of the cases, not all. Treatment will be discussed in the end. The tinea incognito is concerned. Tinea incognito, it is very important terminology, actually it is missed by most of us. The term of the tinea infection that has been misdiagnosed, and inappropriately treated with the topical steroids or other immunosuppressive agents. The clinical feature may become masked with the attenuated scale and erythema as well as less well-defined border. Do not apply steroids. If you apply steroid, the morphology of the lesion will be changed. The infection may also be exacerbated as the dermatophytes invade the dermis or the subcutaneous deeply slightly and causing the deep-seated folliculitis, also referred to as if it is is a palpable mass, which is known as the Majoxi granuloma. The Majoxi granuloma is very rarely seen. I have not seen any case of this, but I've seen this one. And this is a part, on the buttocks. This is the, hole is involved here like this. So it is not diagnosed properly. Actually, you fail to diagnose as something else is there, psoriasis or something else, eczema or others, what is called intertrigo, etc. But this is a fungal infection. It's a tinea incognito. Diagnosis is by the clinical examination, basically. You can use the microscopy and culture and the media, specific media, although it is very, very costly. And also the fungal speciation and viability assessment. The fungal microscopy of the skin scrapings and nail clippings is performed on the potassium hydroxide and can be rapid. If you do the staining with the KOH, fungal culture can take up to 6 weeks, 4 to 6 weeks, but has a false negative rate of at least 30% for nail. It's very, very difficult to go for the culture. Repeat culture should be performed if there is a high index of clinical suspicion. I am say that it should be diagnosed clinically. Now, treatment modalities for all is concerned. First of all, I will say something about the tinea versicolor, that is depigmentation. How will you manage this? So the hygiene should be properly done, and then they should use the anti-dandruff shampoos on the body. One lotion is called selenium sulfite, Selsun Blue. It should be placed on the head as well as all over the body. And daily it should be rubbed on the skin. This is very good management of the area is much higher, larger area is there. Do not use steroids in the tinea versicolor. If you do for 7 days, it will be gone out. Everything will be fine. If it is not, then you go for the systemic therapy like terbinafine or griseofulvin, etc. You can go, but it's rarely, I have not used. I have already managed with these cases with the selenium sulfide. Now, in the other infection, the oral therapy should be considered in the following scenarios: onychomycosis, if there is a nail which is abraded, tinea capitis, extensive tinea on the skin, failed topical treatment, immunocompromised patients. Recommended first line of therapy is the terbinafine 250 mg once a day. For adults, terbinafine is generally safe for use in the healthy patient without the need for the interval blood monitoring. However, it is indicated for the patient with a liver impairment severe, and the dose reduction is required for the patient with the moderate to severe chronic kidney disease. That the clearance creatinine should be less than 50. It should be tapered off. It is half of 250. It means 120 to 125 milligram. Should be given for 3 months. If it is onychomycosis, very resistant infection. The duration of the oral therapy depends on the size. Scalp 4 weeks, fingernails 6 weeks. More than that, I will say it is more than that. I will say it is 12 weeks rather than 6 weeks. Toenails 12 weeks. It is the highest toe nails are involved from the toe area. Longer duration therapy is required because of diminished blood supply in the area, especially in the elderly, and other than the scalp and the nails, they're 2 weeks. Terbinafine. Cochrane review in 2017, they said that terbinafine is superior to the fluconazole, although it is very strong antifungal agent, and itraconazole for both clinical and the mycological cure for the onychomycosis, especially the nails are involved. There has also been difference in the rates of recurrence and adverse events. Griseofulvin for the 6 to 8 weeks pediatric dose is 10 milligram per kilogram, but even up to 500 milligram. The first line of therapy. And this was I'm sorry about it, because I'm not used to a good in handling the computers are concerned. Not very good, very bad in computer handling. So this was the actually discussion. Okay. As far as the topical is concerned, griseofulvin can be used as an alternative to terbinafine, fluconazole, itraconazole can be used. Topical, most cases of tinea corporis, tinea cruris, and tinea pedis are amenable to topical therapy. Recommended first line topical therapy to terbinafine cream is available. Yes, once or twice daily for 1 to 2 weeks is very effective. Otherwise, you go clotrimazole, another cream which is common, quercetin cream. In cases of the onychomycosis, with contraindications of systemic therapy, 9 to 12 months of the what is called is cyclopirox 8% nail liquor once daily. It is not available easily. And amorphine 5% nail liquor once daily in the debridement of the hyperkeratotic nails can be offered, but has a low mycological cure rates of 29 to 36% and 38% respectively. Then laser therapy are using by our dermatology. The cure rates for laser therapy is mycosis are significantly lower than those of topical. You know that cosmetic dermatology in practice, they prefer the laser therapy, but its efficacy is not much than the oral therapy of terbinafine. Given its limited efficacy and high cost, laser therapy cannot be recommended as the first line of treatment. It is the last way to do it. I will say to peel off the nail completely from the nail bed, go for the laser therapy there, use the terbinafine for at least 4 weeks. So relapse will not occur. Prevention. After therapy of the onychomycosis, actually, whatever it is, there may be a recurrence or an infection or reinfection at 25%. Patient should be advised to address a modifiable risk factor prevention of the tinea infection, including avoiding shearing hairbrushes, clothes or shoes, avoiding walking barefoot around the public showers and pools, and regularly alternating footwear and changing stock. Should be whatever taharat is practiced properly. Following a cure, topical antifungal therapy like cyclopirox or amorphine or binofazole or terbinafine is available. Yes, it's very commonly available in Karachi. Can be applied weekly or as prophylaxis. This method has been shown to be significantly lower the recurrence rate. In our retrospective study, definitely. If you apply afterwards only once a week, then the chances are relapse is very minimal. The optimal duration of prophylaxis is unclear and may be indefinite. So I think the thing is this, what I would say is that it is the superficial fungal infection I have discussed. Although I have seen all cases, tinea capitis, whatever infection today is described is seen by me. I have managed myself and I have not referred any case to dermatologist, and they are all cured, alhamdulillah. Because I will also do the prevention. I know how to prevent it. Just to talk to the patient about the hygiene, about the dryness of the skin, should be dried after the bath or after the wuzu or the religious ablution. It should be properly, it should be dry. Inside the nails, inside the interdigital areas, should be dry afterwards. Further manage this case, local, or you can use the oral therapy, and then you go, if it is not effective, go for the laser therapy. Before laser therapy, you go for the debridement of the nail, and then apply the laser therapy will be effective. And then you use terbinafine for a few weeks, and then you will use the weekly terbinafine on the nails for many months. Then it can cure the disease. मेरे मरीज ये कहते हैं कि ये ठीक नहीं होता, अब कुछ भी कर लेंगे ये नहीं जाएगा, ये तो कब्र में जाएगा, यही उनकी बात होती है। यानी इतने उन्हें पता है कि उनकी दादी को हुआ था, उनके मामा को हुआ था, ये ठीक नहीं होता। लेकिन अगर आप इस तरह चलेंगे जैसे मैंने बताया है, I have explained to you, inshallah ta'ala, the superficial mycosis can be cured. Assalamu alaikum wa rahmatullahi wa barakatuhu. Wa ma alayna illal balagh.